panelists?
Yep.
All right. Let me introduce our panellists. So Amelia Berg is developing best practice frameworks, guidelines and training for employing harm reduction peer workers who have living experience of drug use and risk of overdose, as well as providing them with support and supervision. She has worked in harm reduction for over 10 years and is committed to ensuring her peer worker community is well supported within the workplace. Thanks for joining us, Amelia.
Thank you.
Nyachan Nyak is the CEO of the NAS Recovery Centre. Nyachan is the visionary founding CEO of NAS Recovery, delivering culturally sensitive AOD and mental health support to African communities. With over a decade of experience, Nyachan is a recognised advocate for integrated community-based care. Please welcome Nyachan. Angelo Pricolo is a pharmacist. Angelo has been involved in the treatment of addiction for 35 years. His application to the TGA in 2016 saw the down scheduling of naloxone to over-the-counter, and in 2019 he was the first pharmacist to inject a patient with long-acting injectable buprenorphine. That's where we're going to go. Dr. Owne Harris is a GP. With extensive experience across rural, remote and community health settings throughout Australia. He has a particular interest in mental health, alcohol and other drug treatment, LGBTQIA+ health, gender-affirming care, sexual health and child and adolescent medicine with a holistic and person-centred approach. Welcome. I'll now hand over to Brendan, who will take us through the campaign, and you will see a short video as well with some of our panellists represented in the video. So over to you, Brendan. Brendan Park is the Director of Strategic Relations at North Western Melbourne PHN. Thanks, Brendan.
Thanks, Scott. And that's a fancy way of saying I send emails. It's great to be here in Wurundjeri country today and to talk to you all just briefly about why we did this, and then we'll hear from the real experts on the panel. Northwestern Melbourne PHN, in a sentence, we commission stuff, we join stuff up and we make stuff better. I'm here to talk briefly about this campaign, but really it's so amazing to see so many passionate, inspiring people in the room today that do this work. I'm humbled to be part of the sector that does this. But that said, stigma exists. It exists in society, it exists in health systems, it exists in everyday interactions. And so a couple of years ago, our AOD expert advisory group set us a challenge. They wanted us to address stigma, particularly in general practice and pharmacy settings, but in the broader sector, through a behaviour change campaign. And my first thought was, this is going to be hard. It's too tricky, it's too complicated. How can we actually make a difference? Where do we start? But nevertheless, and Scott's on our expert advisory group, thanks for that challenge, Scott, we needed to do it. So I was really worried. I had, as I said, so much respect for all of you, for health professionals like our panel, doing the work that they do, and I was worried about getting the messaging wrong, and my partner works in AOD, so I was worried about offending her, offending our biggest stakeholders, the sector. So we did a bunch of research. We did a literature review, we looked at campaigns here and overseas, we spoke to more than 60 people, focus groups, one-on-one interviews, people with lived experience, all different types of clinicians, people working in administrative roles and practice managers and pharmacy assistants, peer workers, people with lived experience, CEOs, policymakers, academics. What did we learn? Well, there's no magic bullet. I'm sure it'll be no surprise to all of you, but it's really complicated. Stigma exists in individual attitudes, sure, but it exists in society, in culture, in pop culture, in organisations and their policies and their power imbalances and in regulations and funding structures. So even with all the will in the world, no individual practitioner or person is going to overcome stigma. So our campaign needed to acknowledge that. It needed to sound authentic to all of the people working in this space. Our research also reinforced some ideas that our panellists are going to unpack a bit more today. So a couple of those are the idea that AOD is not a moral failure, it's a health issue, but for a multitude of reasons, some clinicians think of AOD differently to the way that they might think about other health issues, be it diabetes or asthma. Perhaps that's because many GPs and pharmacists are trained to fix things, and AOD can be seen as too complex, it's too hard to fix. We'll unpack that. But out of all that, and there's a lot more, but we landed on a concept. It's the idea of raising it. So raising the conversation with patients in a way that's safe and doesn't judge, raising concerns with colleagues, raising your knowledge and curiosity as a health professional, raising your advocacy on this, and ultimately raising the standard of care for everyone, one interaction at a time. To bring this to life, we use a pretty well-worn concept. You've already seen it once today from Sophie, which is the elephant in the room. I know it's a pretty tired metaphor, but we wanted to show that there are layers to the elephant, and that while stigma will never disappear completely, we can reduce its weight by sharing the load and working together. You'll see some of these images in the video in a moment. The other thing that we did was plonk about 30 or so health professionals and policy people in front of a camera for 2 days in a freezing cold Brunswick warehouse a year ago. So thank you again. And I don't think it's where many of them wanted to be, but they spoke from the heart about their experiences of stigma, and it's thought-provoking, it's inspirational, some of it's really heart-wrenching. We got about 4 hours of content out of it, and you'll see some of it today and some of it in your social media feeds, but we're going to use all of that to help drive behaviour change. So by attracting GPs, pharmacists, their front-of-house teams to do a little bit more, whether it's do some training, join a community of practice, refer a patient, perhaps become a prescriber or dispenser, to rethink their signage in the clinic or an attitude or a way of working. I could talk more about the marketing, but I'll put you all to sleep, so I won't. I just want to show about 5 minutes of highlights, and then the panel will unpack that. The last thing I wanted to say, though, is thank you. Thank you for doing the work you do. You're the biggest advocates in this space, and hopefully you can take a little something out of this that helps inspire others around you in your workplaces, but in society at large, to raise the bar even higher, inspire others to follow your lead, because together we can all...
In primary care, it's natural to have lots of questions surrounding alcohol and other drugs. It's okay to not have all the answers, but when you take the step to raise it, something remarkable happens. Things start to become clearer.
Where at first you felt a little unsure, you can now confidently develop a deeper understanding around the issue for you, your team, and your patients.
And by accessing the wide array of services and support available, you'll uncover the right words and actions for every situation.
Together, we can build awareness and foster understanding that alcohol and drug-related challenges are health issues, and anyone can face them.
No one, whether practitioner or patient, should have to face them alone. The more we open up and work as a team, the more we can offer the appropriate care. For better alcohol and other drug support, we can all raise it.
We need to raise the issue of stigma because people's lives depend on it. Anywhere from policy making to practice, stigma infiltrates and impacts what we do.
I remember getting diagnosed with hepatitis C, and when I went to go get a FibroScan, I was asked on just the intake paperwork, how I'd acquired it. So by, the non-blaming methods, like getting it through a blood transfusion. But because I was an injecting drug user, I was really frightened because I thought I'd end up getting treated really differently and, just worse than everybody else just because I inject drugs. And it really made me lose confidence in actually, seeking treatment for my Hep C.
In our culture, using illicit drugs means that you commit a sin. So that's why many clients and their families try not to disclose the situation to other people.
For me, in terms of navigating the mental health and AOD systems, the issue was really the self-stigma and shame that I was carrying for a very long time. I knew I had issues and I wanted to do something about them, but I really just didn't know where to start. I didn't know who to speak to, and I felt really unsafe saying anything. So it took a very long time to reach out and even start that process.
A couple of times when I've been working with someone who was pregnant and had a substance use issue, and they come in for their appointment with the midwife and we chat to them about their pregnancy, they might say, "Oh my gosh, you're the first person that has congratulated me on being pregnant." And that's kind of heartbreaking.
I remember vividly a boxer that came into my pharmacy one time, and I didn't know he was a boxer at the time. I just noticed he had really big hands, like bloody big hands. And I went out and shook hands with him when he first came in, and I remember years later him saying to me, when I'd learnt that he'd been unsuccessful at a couple of other pharmacies that he'd been to and he hadn't been able to stay engaged in the program, and I said, "What was it? What made the difference for you? Why did you manage to stay on my program so much longer?" And he said that the important thing for him was that first day when I went out and I shook hands with him, and he said that no one had ever done that before.
Currently there are so many people suffering in silence with the stigma around treatments. They're too scared to come forward and ask for help, and yet we do have effective treatments.
If we could treat it the same as those other relapsing chronic conditions, like asthma or like diabetes, then what we start to do is normalise treatment. And if we normalise treatment, then people are more likely to come in and to connect with us.
Health professionals often have an approach to treating alcohol or opioids or other drugs as, "You'll do what I say, here's the best thing for you, you need to take my expertise and just do this and you'll be far better off." And that tends to drive people away from care because it's not very empowering, it's very exclusionary.
It's at their time, it's at their pace and how they want to travel on this journey. Of course, we all have our own expectations, what we would like individuals to go through, but we all know that doesn't happen that way. So we have to really just take our time, walk side by side with the client, and understand that most likely there's a reason for everything.
You don't actually have to fix everything, and sometimes you can't fix everything, but you can still make a difference. Sometimes just making somebody laugh or even have a smile for the day is actually what matters to people.
We're just like everybody else, we have our challenges, we have, differing levels of health or mental health, and that we're actually deserving of the same healthcare and support as anyone else in our community. So make us feel welcome and treat us with respect, and, we'll go the journey with you and get better health outcomes for ourselves. And you'll enjoy it better too.
The video working. What I'd like to start with, if I can, is thinking about stigma, not just what it looks like, but I'd encourage you to touch on that. What does stigma look like? But could you talk a little bit, and I might start with you, Amelia, if you don't mind.
Yeah.
And you could potentially talk to one of the experiences that was on the video.
Yeah.
What does it look like, but what does it feel like? And I might ask you to sort of respond to that if you don't mind, and then Owen, you might have a word or two saying that as well.
Yeah, that saying, sticks and stones may break my bones, but names or words will never hurt me. Yeah, that's bullshit. Stigma hurts. You know when someone's, thinking something bad about you, when they're talking or speaking to you differently than they would other people. It actually really does hurt. Your heart does break a little bit on the inside each time. It's so othering, and you know exactly what that person's really thinking about you. So it really does, it's depressing, and it makes you want to just shrink into this little ball and just not be there and do anything you can to get away from that situation, because, you know, it's so painful knowing that someone thinks something awful of you. And, you know, when you're going into a health service, you know, one single interaction like that can mean that you don't come back ever again, because, you know, we try not to put ourselves in hurtful situations. You know, that's generally how people try to do things. But yeah, when you have that interaction, like I remember in the video, I told a story about how when I'd gone to get a fibro scan because I'd tested positive for hepatitis C. And I was just filling out the intake form at the hospital. I won't say where it was. But, you know, one of the big questions that they wanted to know was, how was I infected? You know, blood transfusion or, you know, injecting drug use. And I'm like, oh, I didn't know. I didn't realise I didn't have to fill that question out. I just, you know, felt shit doing it and, you know, ticked my little box of injecting drug use, thinking, are they going to think, you know, are they going to treat me differently? You know, it was terrifying because I don't know, like, you know, yeah, okay, I inject drugs, but that doesn't mean I'm a bad person. But, you know, am I going to get treated differently and, you know, or not get the proper care that I need? And it wasn't relevant to the reason I was there. You know, I was getting a thing that goes jab, 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 doesn't even go into you. It's not an invasive procedure at all. But so why did it matter? But it was asked, and it, you know, it frightens you knowing that, you know, there's that chance that you're going to be treated differently to other people just because of something you do. You know, it's not even who I am. You know, I'm more than just my drug use. But it really, internally, it really felt like that's what I was reduced to in that moment. So it's really painful.
Thanks, Amelia. Would you like to add to that? Because I think, Amelia, you touch on a sort of a concept that's probably even more powerful, and that's self-stigma, the shame that you can bring to yourself. And Owen, you might have a view on that as well from your professional and personal background.
Yeah, firstly, I'll say the bio was true. I am a GP, but it's I was a bit late sending the bio that I was supposed to for this event. And yeah, that includes that I have lived experience of complex mental health and substance use disorder. And yeah, absolutely, I completely agree with what Amelia has said. For me, yeah, it's a very painful feeling of being othered and being unsafe, feeling unsafe to disclose, what has been happening or what I need, or ask for help. And it's something I felt very often in situations where I might not have thought it was going to happen. And it was a really intense feeling of wanting to protect myself in any way possible, and that might mean playing up my symptoms, or it might mean not disclosing symptoms, or certainly not asking for help when I really knew that I needed it. As you said, Scott, for me, a lot of it was self-stigma. My substance use issues started early in life, as they do for many people, but they didn't really become very, very problematic until much later. And I was working full-time as a GP. On surface level, I seemed to be doing quite well. I certainly wasn't treating my patients in a way that I thought was stigmatizing, but I felt that I couldn't reach out for a number of reasons, it was definitely a sense that I should know better, or I should be able to sort things out myself, and also that it was just deeply unsafe to ask for help. And that was partly medical board issues and feeling like my entire career was at risk. But it was really the idea that I didn't deserve help because I shouldn't have got myself into the situation that I was in. And that's, clearly not how I feel about things now. Even just talking about it, I immediately feel that really unsafe feeling, and it's deeply uncomfortable. And now in my working career, I see many people with substance use disorder or other mental health issues as well. I see many sex workers, and I see a lot of people for gender affirming care, and it's kind of heartbreaking to me when people come in and they're clearly very guarded for obvious reasons from their previous experiences, and when they do start to feel more relaxed and comfortable and safe, and I'm incredibly grateful for that. I always think, how is the bar that low elsewhere? How bad was their experiences? But I mean, it happens so regularly that the stigma is very real, and it's institutional, and I'm glad we're doing something about it.
Thanks, Owen, for sharing that. Yeah. Angelo, would you like to make a comment? And then I want to also pick up, there were quite a few shoulds in what you just said. So I'd like to touch on shouldn't, and expectations. I'd like to bring Nyachan in to talk a little bit about expectations in her community. But off you go, Angelo.
I was just going to pick up on something that Amelia said in terms of the way you're being treated, and in the pharmacy setting, I found that I could be as normalising as I wanted in my approach, but I was in a setting where there could have been 10 or 15 other people in the vicinity, because that's the way pharmacy works, and I found myself trying to compensate for the people around who I was dosing or treating. And, the way I did it was often to go out into the shop, stop what I was doing, and start a conversation with the person I was treating to show that they were human and that I was interested in something else other than the dosing. And I found that was kind of disarming for the other people that were, sometimes even not realising themselves, maybe subconsciously staring or judging, but by doing that I sort of felt as though I was including them into the circle and normalising the treatment, because I would do that with other people too. I'd have a conversation outside of their diabetic medication or their asthma medication, and so it's an interesting setting, pharmacy, because it's not just one-on-one. It's a little bit different to sitting in a room with somebody. You're constantly looking at the whole surround, and that can be more challenging, or you can use it to help.
Well said, thank you. Nyachan, would you like to touch on stigma in the context of African communities and your experience at NAS Recovery, thinking about maybe some additional burdens and barriers?
Sure. First, I want to acknowledge that we are sitting on the unceded land of Aboriginal people, and I pay my respect to the elders past, present, and as a thriving migrant refugee who's enjoying this wonderful land, I'm very mindful of the experience, the injustice that the community continue to experience, and I value your resilience and wisdom, and we're learning from you. So anyone from the room, from Torres Strait Islander and Aboriginal community, thank you. Yeah, so my name is Nyachan. The experience I'm going to be sharing along this panel are both my professional experience and also lived experience. Owen talked about the should and could and the expectations, and I just wanted to, I guess from my observation, but also from my personal experience, the intersections of expectations and stigma weigh really heavily for people who are coming to this country for a better life. When we come here with high hopes, high expectations on ourselves, on our community, high hopes to give back to the country that welcomed us in, but also a high hope to change the circumstances of the country we fled. And so that comes with, we cannot drop the ball, we cannot have mental health issues. And it doesn't come from ignorance that mental health or drug use doesn't exist. It does, even in our country. In fact, in our country, we see it. My dad and stepmom used to make alcohol and they would drink it, and it was a very simple way of celebrating. And when people did develop addiction, they would heal within the community. We didn't have rehabs. So it wasn't something that's supposed to be shameful and embarrassing. It's something that we experienced within the community. We healed, we got better. But somehow we came to this country where we have, again, high hopes and expectations to give back here, to give back to our country. We forget what it means to be a human, and we become stuck on survival and fixing and taking and thriving. And so what happens with that is the stigma, stigma exists everywhere. But when our community when someone from my community have stigma, it's intensified by expectations. So it's a stigma that, this is a moral failure, this is weakness, this is a white privilege, this is a Western issue. That's one. But also you should know better and you should do better. And therefore, if you don't, you deserve to be punished, to be embarrassed, to be distrusted, to be disrespected. And even after the recovery, you are still a failure. So even well after you've done all the work and changed your life around, you still don't measure up to what another person who didn't have that journey, and it makes it really hard. And Amelia was talking about how stigma hurts. Just you can imagine, it's like you see when someone from our community, they may see another person from a Western community having addiction, and they will say, "Oh, poor them. I hope they get better," right? So their heart opens up and they seem to have understanding. They'll see someone from African background, they say, "How dare you let us down," right? So that's literally what the stigma feels like. So for practitioners that may be in the room is, sometimes when I'm in rooms and people are talking about cult communities, there's perception that cult communities don't understand drug use, they don't understand mental health, and that they need to be educated. It's not that they don't understand. Their heart has tightened because of the expectations, so they won't open up. They will refuse to acknowledge that anyone can have addiction because of that expectation. So it's like one person, one community can have addiction and it's fine, we understand it, and one community is a no-no because we are here for a better life. So I think that's what makes it difficult, and that's what makes it difficult to change people who are from that community when you are mixing expectation with stigma. Does that make sense?
Mm-hmm. Thanks, Nyachan. Could I invite the panel to offer some reflections on Nyachan's comments?
Obviously I can only speak from my own experience, but that certainly resonated with me also. And the idea of shoulds and expectation, I clearly don't think that about my journey now, and if anything it was kind of inevitable that I ended up where I did, just given the family upbringing that I had and the circumstances around that, and the added kind of complexities of the medical board and the barriers that created to seeking help. But there was a really, really strong sense that I just couldn't tell anyone about what was going on because it was unsafe to do, and that comes back to the stigma, and also just that I didn't believe that it was a problem that I would have or could have, and if I did have that problem, then given my clinical knowledge and resources and other things, then I had this idea that I should be able to just treat myself or not need treatment. For a long time there were kind of two opposing ideas in my head, that I could just stop using tomorrow, so I'll just keep using, and also I'm so unwell I'll never actually get better, I'll never be able to jump through the hoops required by the medical board, so why bother even trying? Both were untrue, but it was this idea that I was somehow different to other people, and not that getting treatment is easy by any means, but the first part is actually telling someone about it and getting help, and treating myself like I would other people as well.
Yeah, I think it's really, really hard when expectations come up, because everyone seems to have, some idea of, what we should be doing with our lives, even if they don't even know us. There's always that idea that, you should be doing this particular thing, and why would you do that thing? And, there's a lot of reasons that we do what we do. It doesn't change who we are as people. We're still people, but so often that stigma comes up and we're not treated like people, and like even going to pharmacies. I'm lucky I've got a great pharmacist that I go to for my methadone. They're awesome, but I do hear horror stories as well of, people that are made to sit there for an hour waiting for their dose while they're seeing, so many people come in, drop their script off, getting spoken to really nicely and not being made to wait. But then also you're not allowed to leave that chair because, we're all light-fingered and we're all going to steal your stuff from your shop. Like, you don't want me in your shop, but you want me to sit in your shop. Like, it's heartbreaking when you hear those stories of people that, they're not feeling well, they're sick, they're in withdrawal, waiting, and they know they're being treated differently than everybody else. And, that's accessing, basic healthcare. And it's, those kind of encounters that we have over and over and over again, they wear you down. And, you get that feeling of, I'm only going to try so many times as well.
Yeah, absolutely. And I just want to say two things. I think there's an idea that people make bad choices, and I certainly had this idea in my head and for a long time, and would kind of ruminate on things that I had done or had happened. And it was a psychologist who pointed out to me that, if you've only got bad options, then you can only make bad choices. Once you have more options, then that's different. And also there's another idea that if a person has gone to rehab or done some sort of recovery, then they should remain abstinent forever, which is clearly absurd and not a goal for many people. And so it was, that was another aspect, even once I was in active recovery, that I was still experiencing self-stigma because I felt like I'd failed if I didn't have a perfect kind of abstinence-based recovery. And again, that was further complicated by the medical board, who have no idea about how to treat substance use disorder, but that's not for today.
Yeah, just quickly, I just wanted to find out where the bad pharmacy was so I can go and visit them.
There's quite a few, unfortunately.
I can go see them all. It's interesting what you said about the cultural aspect of. I remember I did quite a bit of work in the early days with the Vietnamese community, and about 20 years ago, I made a film. I made a documentary about addiction, and I wanted the Vietnamese community to be represented in it, but I couldn't get anybody. And I had over maybe 120 people at that stage on my program, and there were probably 20 from that background, but none of them would speak on the doco. And some of them I'd known for many years, and they said something to me repeatedly that then made me understand that it was a cultural. They just could not admit to their wider community that they had a problem, and that meant not talking about it with their family or their network. And I just kept relating that story and thinking, how hard is it going to be to get better if the people around you aren't supportive? And it really made their journey that much more difficult because their network, couldn't be involved.
Yeah.
Nyachan, can I bring you in to that, thinking about, and the phrase I'm going to use is blind spots, because I think it's one thing for us as AOD clinicians to make an assumption that we don't bring stigma or into the relationship with our clients or our patients, but yet I think we need to be careful there with that assumption, thinking about our sector, thinking about potentially a lack of representation in our sector from diverse communities. How might our sector be seen potentially by African communities, and can they would they perceive our sector as a place where they can get help and support?
Yeah. Yeah, that's a really good point. First of all, so I'm just going to be honest here. Sometimes people who are experts in the fields may not even think they can have stigma, because they educated, well informed in drug use and all that, and they don't have stigma. And I was thinking about this campaign, about raising it, and I'm like, okay, it's really great that we're raising awareness about stigma, but I think the intersection of stigma and racism and discrimination and prejudice still go together, and they cannot be missed out in conversation, because what we're doing is people then can say, well, it's like saying I don't see color. I don't hold stigma, but then maybe you hold very unhelpful beliefs about particular community, about particular religion, about particular people, about particular gender. So what happens then, right? Because the symptoms and the trait and the treatment is very similar, right? And so for the person on the receiving end, they may be sitting there thinking, oh, they stigmatize it. They giving me stigma, but they actually don't realize maybe it's not even stigma. It's other things, it's other, perceptions they have about you and about your identity. So how can the sector change that is, one, the reducing of stigma and anti-racism needs to go hand in hand, because one, you will reduce one, the other will still go up anyway, especially with communities that are already marginalized and facing various barriers to support. The community in the, I always said the first 5 years when people are settling here, they're in survival mode, they just want a roof, food and whatnot, and they're not even paying attention to the sector, okay? They're not paying attention to mental health, they're not paying attention to anything, just the basic needs. But after the 5 years, people settle, people have a safe roof, food on the table, now they're thinking about what else do I need? What other support do I need? What healthcare access do I need for untreated trauma, for untreated health issues, for addiction that may be manifesting in the house? And their first experience to the sector, if it's negative, people will retreat and they're not going to come back, and communities talk. So at the moment, there's few people who may use the service and had really good experience, and there's a great services around and service providers that are doing great work in helping everybody. But there's also a huge number of people that are not accessing help because either their first experience was negative or they don't see representation. And sometimes when we talk about representation, it may be like, boo-hoo, you want representation. But I tell you why that matters. When people can see themselves and people that are treating them, you are normalizing it. You're normalizing that this is an issue that doesn't just impact this side of the room, impacts everybody, and that's why there's everybody working in the sector. So you are telling people that it's not a particular community or people who look like this who study that issue and want to help people who look like this. You are normalizing it. That's why representation is matter. The other reason that matter is also that you can't train your way out of learning about communities, their way of life. Just be with them, work with them. And so the sector can do better. It can start at school, making sure that these modules and encouraging people to become, addiction specialists and whatnot is encouraged at the early stages in school. So young people from communities that don't often hear about this can take up those courses and then become representative in their community, and it can build trust between what's already exists and the communities that don't use those services. So it's a longer way, but look, it's getting better, it's getting there, but we could do better.
Thanks, Nyachan. I want to talk a little bit and move a little bit towards what to do about some of these issues and where do we take some of these issues. And I'm going to quote Cherie Lowe from her presentation earlier because I thought it was relevant. Cherie talked about going beyond substance use, relationships coming before interventions, and trust before treatment. She also talked about starting small within their sphere of influence. Would anyone like to touch on the issue of relationships and the importance of relationships, trust, and some of those themes in terms of the response to stigma?
Yeah, I think when we're talking about drugs and alcohol, but particularly drugs in this instance, when you're looking at something a behaviour that's criminalised, drug use, that makes it even harder for people to, ask for help or support, or even just mention the fact that, hey, I do that thing. So that's something to really remember, that, you're putting yourself at risk by admitting that, potentially. And I think, when we look at stigma and research that's been done into stigma and healthcare professionals, we've seen that there is there's awareness that, stigma is quite bad within healthcare professionals, and people are able to identify it in others, but research has also shown that they're not as good at identifying it in themselves. I think one thing that we need to do vocally and, really loudly is, raising it, call it out. If you see it in co-workers, call it out that, that's just not on, and, remind the sector that, we've got to actually actively combat stigma. You can't just ignore it, and you can't just, pretend that it didn't happen. If you do witness stigma, discrimination, anything like that, you need to, even if it does put you on the outer, of the group, you need to say something, because not enough people do. And, that's just stops us from, being able to trust. It's hard, like with representation, we also have that as well for people who use drugs. When we see peer workers, we're automatically comfortable because we know that you get it and that you're not going to be shaming us or treating us differently because, you've been there or you're currently there potentially. So having that automatic connection, it's so much easier to open up. But, it takes time, and, chances are people won't disclose everything, all at once because it's hard, it's scary, and, you're anticipating a bad reaction. But if you get to have that time to actually get to know someone, or you see someone that you can actually identify with, then it does make it easier. But, collectively we've got to stand up and shout out when we hear or see, stigma and discrimination. Definitely.
I was just going to add on to, circle of influence, families, okay? Families, especially in communities where seeking help outside a family is foreign. We come from big families, which means the circle of where we can get help is usually bigger before we come to services. Culturally, like I said before, in our communities, we used to heal within the communities. There was no outside because family goes beyond your two siblings. We come from 8 families, 12 families, plus step-parents, plus cousins and cousins and cousins. So therefore, there's always someone we can confide in before we go to the professional help. So I think for the sector to recognize that as a strength, because if you supporting a person that comes from a big family, how you have to create circles of kind of what informal support is. This person essentially has so many people that can support them, which is good for you, because if we complain about the wait list and there's no times and shortage, use family members. They are informal support, but the most important support and more sustainable support that you can help someone. So when you're working with a person, ask them who's their family, who's their favorite cousin that can be part of this journey, and that's their circle of influence, and that's also your circle of influence as a practitioner that can utilize that. Faith leaders, I think we forget the influence that faith community have over a vast number of people, right? They have followers, and sometimes faith communities, I'm Christian, but Christian spaces can be very stigmatizing, right? And there could be so many misconceptions around moral failure, sin, and all that stuff that that I don't even think the Bible says that. I think it's just people using Bible as a way of scapegoating their own issues, but training and educating them and empowering them to be positive influence, right, is important. So sometimes our intake forms don't really ask what faith group do you belong to. We just assume it doesn't exist. But yeah, I think faith religious groups can be part of the influence and part of support and families.
Yeah, I think in general practice and in medicine generally, what I think the kind of biggest factors are funding, education and exposure. I mean, medical students and junior doctors spend time in emergency departments before they spend time elsewhere, if they even do work in drug and alcohol services or psychiatry. And yeah, obviously their experience of patients acutely affected by substances and what we call the frequent flyers or attitudes to people who are in emergency often will impact their choices in careers and how they treat people down the track. I think the government's plans around bulk billing, I can understand what they're trying to achieve, but actually it's really just pushing 6-minute medicine, and that's really not going to build any relationships. I think we need to change the funding model for all of general practice, really. And I think the earlier we can educate students and GPs around what AOD work actually looks like, the more likely they are to be interested. And that happens all the time when I see registrars who come into the practice and they've had no experience or interest previously, but if they're forced to see a few of my patients, their attitudes change immediately. So just try and dump patients on them when I can. And yeah, the long-acting injectables have made a huge difference as well. It really is very easy medicine and yeah, life-changing for many people. Having recognised addiction medicine physicians is certainly going to help as well, and we need more. They also need to be funded properly. And yeah, on an individual level, I think we also need to change the culture in medicine of trying to fix everything. And really, yeah, I don't understand why doctors don't get as frustrated with their diabetic patients who are not taking their medications in the same way that they get frustrated with patients with AOD issues. But that's a cultural shift that's going to take a lot of time. But yeah, this campaign is definitely something that I'm hopeful for.
Well said. Thanks. And Angelo,
I just wanted to reinforce, how important the networks are around that person that we're trying to help, because usually the amount of time that I potentially have to spend with someone is quite limited, and then they're left to their network, the people around them. And if my message is positive but everybody else around them in the rest of their day is negative, then I think that one is just reinforced so much more, not just because of time, but also because of who it's coming from. And so I think part of my job has always been to try and include that network. And maybe it is picking the people who are positive and supportive and bringing them on the journey as well, because they can then do a lot of my work. If I can educate and teach them and bring them on the journey. But as far as the relationships go and how important that is.
All right, we might finish up there while the other sessions rejoin us. But if you don't mind, please thank Angelo, Amelia, Nyachan, Owne and Brendan and Dad.